Welcome back, ladies and gentlemen. Now let us move on to the first symposium for the day on radiology. We invite the chairpersons, consultant respiratory physician Dr. Ishant Pereira and consultant radiologist Dr. Shanta Hettiarachchi to introduce the speakers.
Good morning. We have a first symposium of the sessions. There's on radiology. We have 4 speakers on talking about different aspects of radiology in matters to respiratory medicine. And our first speaker is Dr. Samman Kularatna. He's a senior consultant respiratory physician at National Hospital for Respiratory Diseases at Sri Lanka. May I call upon someone to start deliver his talk on interpretation of chest X-rays in clinical practice.
Good morning, everybody. So I'm supposed to talk on a radiology topic in front of 3 eminent radiologists. Interpretation of chest X-ray in clinical practice. You might wonder why I started with a back X-ray. So this patient presented to us last week with history of back pain, and somebody has done a spine X-ray and found some abnormalities without doing a chest radiograph. And then they have done various other investigations on the line of excluding myeloma, other X-rays, then serum protein erythropoiesis, trephine biopsy, upper GI endoscopy. So finally they have done a chest X-ray and came to us. The take-home message here is, you are supposed to do a chest X-ray at the same time when you do some other X-ray. So start with the chest radiograph. When you read X-rays, first of all, anyway, you are supposed to do the identification and look for rotation and look for the exposure and whether it is inspiratory or not. And then start reading the chest X-ray. So you all have to have some kind of definite order to read the X-rays. So I'll start with this radiograph. And this patient is a 17-year-old girl who came to us with evidence of disseminated TB. And she has been ill for the last 1 year, and she was carrying this X-ray. Just see this X-ray, and she has had right paratracheal opacity with evidence of lymphadenopathy. So finally, she ended up with laparoscopic removal of tubes. So a lot of complications of tuberculosis. And if you miss subtle changes there, so that will be the end result. So start with the trachea and look at the paratracheal area. So you will have few millimeters of soft tissues in the paratracheal area. So there is lymphadenopathy. Now look at the hilum next. So hilar vessels. The left hilar vessels are slightly higher level placed than the right. And in my next X-ray, you can see a hilar adenopathy. So easily you can overlook this finding. Look carefully for the hilum for lymphadenopathy. And this one, it is obvious you have bilateral hilar lymphadenopathy. Then you can see 2 masses either side. In the right mid-zone and the left mid-zone. The important thing that you can notice here is through these opacity, you can see the vessels. Through these, the opacity, you can appreciate the vessels. And in this X-ray, you won't be able to see the ascending aorta. So very likely this mass is touching the ascending aorta, and it is in front of the hilar vessels. So if you look at this X-ray, there is a mass, and through that mass, you can see the vessels. So you can't appreciate the left heart border here. So very likely this mass is touching the left heart border anteriorly. So this mass is anteriorly placed. So this is called hilum ovale sign, and these two patients have mediastinal, anterior mediastinal tumors. So in this X-ray, you can nicely see the right hilum, and then there is a separate opacity, and you can appreciate the vessels also. So if you do a lateral X-ray, you can see, and these opacities are behind the vessels. In my next X-ray, you can nicely see these vessels, and you can nicely see the ascending aorta. So this mass is not touching the ascending aorta, it should be behind that. So I don't have a lateral X-ray. This is a posterior place mass lesion. If you look at this X-ray, the other one, you can't see the vessels, and there is a big mass, and you can't demonstrate the ascending aorta, and there is paratracheally that mass is ascending there. So this is a hilar mass encroaching the vessels and coming up to the ascending aorta level. Right, this is just to show you the position of the transverse fissure. This is one of our TB patients with bilateral opacities and costophrenic angle blunting with some fluid there. So this is the position of the transverse fissure. It touches the 6th rib laterally. So if you look at this X-ray, the transverse fissure is moving up, and then there is opacity, and you can vaguely see a reversed S sign there. So this is a patient with right upper lobe mass with collapsed upper lobe. Similar patient, you can see a right upper lobe opacity, and the trachea is deviating there. There is volume impairment in the right side. So always look at the trachea there. Sometimes you can see a mass lesion within the trachea. So this is again a right upper lobe collapse. Now if you look at the lateral X-ray here, in the right side, you will see the oblique fissure like this, and the transverse fissure like this. And you can see the middle lobe here, which is touching the right heart border, and then the right upper lobe here, and the lower lobe there. In a lateral X-ray, you can see two thoracic cage lines. The reason is when you do this is a right lateral X-ray. In fact, when you do a right lateral X-ray, you will keep the right side onto the X-ray plate, and your beam is divergent beam. So you will see the left side getting displaced out. So this is the left. So starting from left, it is the left hemidiaphragm. Starting from right, it is the right hemidiaphragm. So any pathology next to the heart will be in the middle lobe. So you can see opacity here, which is touching the right heart border, and you can't demonstrate the right heart border, so it should be in the middle lobe. So it's a lateral X-ray showing the middle lobe, so collapsing right middle lobe. And then look at this X-ray. There is opacity next to the right heart border, the right atrium, and the right heart border is obscured here, so do a lateral. So again you can see a collapsing middle lobe. In this X-ray, it's a patient, the young girl with tuberculosis, and you can see cavitating lesions, but you can nicely demonstrate the right heart border. So it should be behind the right middle lobe. It should be in the lower lobe with a cavitating lesion in the apical segment. Whereas in this X-ray, you can't demonstrate the right heart border. You can't see the right hemidiaphragm, and there is some pleural reaction here. In fact, this patient had a complete obstruction at the truncus intermedius, causing complete collapse of the middle and the lower lobes. Now moving to right hemidiaphragm, the right hemidiaphragm is slightly higher level placed than the left, and in this X-ray there is grossly elevated right hemidiaphragm, and you can notice this is underexposed film with some obesity. So if you see this elevation, there are two things that you have to consider. One is subpulmonary pleural effusion, other one is a paralyzed hemidiaphragm. So you are supposed to do a ultrasound scan and see whether there is paradoxical movement of the right hemidiaphragm. So this is just to show you the blunting of costophrenic angle. So early pleural effusions can cause this, and even pleural thickening can cause this. But remember, in pleural effusions, at the early stage, so if there is a patient with, pleuritic type of chest pain, fever, and your PA film might not show the pleural effusion, so you have to do a lateral X-ray and look at the posterior costophrenic angle. See all these things. Now this one you can see the encysted fluid in the left lower zone, which is suggestive of a exudative pleural effusion, because for you to get encystation, you have to have a lot of proteins. Another patient with the pleural effusion in a TB patient. And this one, you can't see the right hemidiaphragm, right heart border. And again, there is a pleural effusion. And you can see some fluid in the transverse fissure, which is in the correct position. And then opacity here, which is suggestive of a collection of fluid within the fissures. So this is called pseudotumor appearance. And you might come across these type of encysted pleural effusions every day. When you see this, if the patient is ill and toxic, always then and there you have to aspirate and see whether there is pus or put an IC tube, and don't wait for the next day, because the patient might become septic next day. So there are other changes you can see similar to pleural effusion. It's like an encysted effusion, but you can't demonstrate the descending aorta here. This is in fact a big aortic aneurysm. The other X-ray, you can see it also mimics a pleural effusion, but this is not a homogeneous opacity, or the heart is shifted to the other side, and you can see the bowel shadows there. So this is actually diaphragmatic hernia. Coming on to the left side, this is the left side. You have left upper lobe and the lower lobe, and see the changes there. If the lower lobe is going to collapse, it will collapse downward and stays behind the heart. So these two pictures shows behind the heart opacities. So always look for the descending aorta, and you can't see the descending aorta here. You can't see the upper border of the left hemidiaphragm, and these are important sites to look for. Even this one has a left lower lobe collapse. Another patient, ICU patient, you can see this is inward AP film, and if they become suddenly hypoxic, so do X-ray. Now we can see the shifting of the cardiac shadow this way, and there is behind the heart opacity. So in this case, you are supposed to do bronchoscopy and see. Another behind the heart opacity, you can see, you can't appreciate the descending aorta here, and you can see the left heart border nicely. So there is opacity behind the heart with some air bronchogram effect. So opacity with air bronchogram, you know that is going to be a consolidation. So it could be a pneumonic consolidation. If not responding, think of other possibilities like alveolar cell CA. Another patient with opacity with air bronchogram effect suggesting consolidation. So this is again the oblique fissure. So so this is the upper lobe. You know the upper lobe bronchus divides into upper division and the lingular lobe. So this X-ray, you can see the left heart border is obscured, and there is opacity with a cavity, and you can nicely see the oblique fissure here. So this opacity is in the left lingular lobe. Then I don't have a proper upper division opacity, but this is a post-TB patient, and you can see the left heart border nicely. So this is these changes, the fibrotic changes, everything post-TB changes in the left upper division. This is another patient. You can see the oblique fissure moving anteriorly, and this is the hyperinflated left lower lobe, and this is what you see in left upper lobe collapse. So the upper lobe collapses anteriorly, so you will see what is called whale sign here, and because the left lower lobe is nicely emphysematous, you can nicely see the descending aorta and the left hemidiaphragm. Sometimes you can see this apical segment of the left lower lobe coming through in between these collapsed upper lobe and the aortic knuckle as a normal shape, crescent shape opacity. These are the X-ray. You can see both the total collapse of lungs. So you can see the tracheal deviation, you can see the moving of the heart to the other side. I don't know whether there is some fluid inside, but always look at the entrance to main bronchus and see whether there are some opacities here. So this is the left lung collapse. You can see the mediastinal shifting to the left side and tracheal deviation, and the diaphragm is somewhere here, and this appearance is called bronchial cutoff. In fact, this patient had a major bronchus obstruction during bronchoscopic examination. Next, I'll come to this area, although this patient has a opacity next to the left heart border, suggesting the opacity is in the left lingular lobe, and this area is called the aortopulmonary window. And any patients with hoarseness of voice, think of left the aortopulmonary window opacity. So this is the aortopulmonary window opacity. Next, move on to the aorta. So always you know the cardiac size and the size of the aorta. So you should have seen a lot of X-rays to appreciate that. So you can see big aortic knuckle here. And here again, I can't demonstrate the left, descending aorta here. The aorta is coming in this way. So both these patients have dissecting aortic aneurysm. Now look at the pulmonary arteries. So is the patient, you can see hyperinflated in the lungs with flat diaphragms, and it's a rotated film. You can see right pulmonary vessels prominently, and this is the main pulmonary artery. And in this X-ray, it's a post-TB patients. You can see these both hilum moving up due to fibrosis and prominent hilar vessels. So think of pulmonary hypertension then. This one, obviously, you know the miliary mottling, 1 to 3 millimeter mottling. So there are a lot of causes. So think of all the causes. And the next X-ray, this one shows patchy opacities, bilateral, ill-defined. Always examine and see whether there are secondary deposits everywhere. This is very suggestive of pulmonary metastasis, but you have to always think of other possibilities like atypical infections and the vasculitis, so on. Here you can see opacity here, but before sending these patients for CT scanning, just examine again. So this, this nodular opacity which is there in the skin is shown here. Right, these are some of our TB patients. It is very important to diagnose the PTB early. So it is again young patients with TB. And this is what happens if you don't diagnose TB early. So bilateral cavities, bilateral opacities. So this is the type of patients that we see in Valisera, all are drug addicts. And I don't know how to control TB when you have these kind of X-rays. Another X-ray, you can see a cavitating lesion with a fluid level, and we call it lung abscess. You can nicely see the lung abscess in the apical posterior area, and you can demonstrate the oblique fissure and the transverse fissure here. So these are some cavities. You know the cavity, there are a lot of causes for cavitating lung disease. So this is a smooth cavity which is in the apical segment of the lower lobe right side. It's a common site for TB. And just look at these cavities. These are post-TB cavity filled up with some mycetoma. Always consider other possibilities like malignancies, blood clots, everything. So this cavity and this one, you can see very irregular inside suggesting a cavitating malignancy. Even this one is a cavitating malignancy. This is just to show you some bronchial changes. Always look at the right and left. So dextrocardia with bronchiectasis. So to confirm that, you are supposed to do high resolution CT. And these two patients were hypoxic with very subtle X-ray changes. So always consider there are possibilities atypical infections, especially pneumocystis carinii these days. So examine the mouth and look for extensive candidiasis in this patient. This is another patient who came. So those two patients were HIV positive. Very subtle changes. Always consider the other possibilities like acute HP and AIP, and also remember the pulmonary embolism also if there are very little changes. Right. This one came last week with bilateral extensive opacities. The patient is hypoxic, the young patient, and this X-ray had been done some 1.5 years back. So you should have noticed the possible lymphadenopathy, possible fine changes, they are suggestive of ILD. So all these fibrosis should have been prevented if you detected at this time. So the diagnosis was NSIP here. So these are actually honeycombing following pulmonary fibrosis. You know the honeycomb appearance says that there is the late stage of pulmonary fibrosis. And important to detect the pneumothorax, so very small pneumothorax here. And in our setup, there are a lot of TB patients, they come with encysted pneumothorax lower zone. So if you don't have previous x-rays, it is difficult to confirm the diagnosis. So always consider pneumothorax, and sometimes the X-ray may be normal in ICU patients. You may need HRCT and all. Remember these appearance. These are all skin tags. When you diagnose, when you try to put IC tube, be careful. These are not in the pneumothorax. And another patient with big emphysematous bullous lesion here. Sometimes it's difficult to differentiate this from the encysted pneumothorax. I have few more slides. Just appreciate the bones after that. So this patient has multiple myeloma with very extensive osteoporosis. And these are COPD patients who came with extensive bone sclerosis. So appreciate the bones also. And another patient with the lytic lesions in the bone. So I have only 2 more slides, and this shows the cardiomegaly. They can present with fever, febrile illness, and bilateral pleural effusion. And always listen to the heart, look for triple rhythm, look for evidence of cardiac failure. So you can see bilateral perihyle opacities with prominent upper lobe vessels. This is pulmonary edema. And this X-ray, you can see nice outline with some pleural effusion, pleural reaction here. So this is a patient with pericardial effusion. And this is my last slide. And it's a nice cardiomegaly. You know that with these, more than 50% of the width of the thoracic cavity, we call it cardiomegaly. But look at the left ventricle. Left ventricle is fairly okay. And you can see the left atrial appendage, which is dilated. You can see the white splayed out carina, and you can see the double atrial shadow, and you can see the bulging right atrium. So this is a case of tight mitral stenosis. So chest X-ray interpretation. When you see the next lectures, you will realize the radiologists have enough work. And they are busy with the CT, ultrasound, MRI scanning, and various procedures. So it is the duty of the physicians to look after chest X-rays, but I don't think the radiologists have enough time to go through each and every chest X-rays done in hospitals. Thank you very much.
Thank you, Dr. Kularatne, for this talk on a common investigation with diverse possibilities. Thank you so much. We'll take up the questions at the end of the session.
The next lecture is on place of HRCT in respiratory practice, and I invite Dr. Bhavin Jankaria from India to deliver the lecture. Over to you.
Yeah, thank you so much for the invitation, and it's always a pleasure to come to Sri Lanka. I think it's my 5th time here. And I'll spend the next about 17 odd minutes talking about the role of HRCT in respiratory practice. And it's a little more than just interstitial lung diseases, and so we'll cover bronchiectasis, emphysema and small airways disease, and cystic lung disease as well. If I can just have a show of hands, how many of you are doctors in training, and how many trainee doctors in pulmonology or physicians? Perfect, and then everybody else is a consultant. All right, great. So it's just an overview, and it should hopefully stimulate you to understand, how we use CT on a day-to-day basis, and then perhaps read more and get more out of this. So what is bronchiectasis? It's irreversible localized or diffuse dilatation, and what we use CT for is diagnosis, sometimes to find the etiology, and then to look at associated small airways disease. The diagnosis of bronchiectasis involves these three parameters, basically when the airway is larger than the artery, and then the other two that you see here, and I'll just show that with examples. So there is some debate about whether we should measure from the outer diameter to the outer diameter or use the inner diameter. It doesn't really matter. Nobody measures except when you're doing clinical trials, and what we really do is just eyeball. So whenever you see the bronchus larger than the accompanying artery, that's bronchiectasis. And when you see them side by side like this, this is also called the signet ring sign. When bronchioles, they branch out and you do not see tapering, then that's a sign of bronchiectasis or bronchiolectasis. And if you see bronchioles in the last 1 to 2 centimeters of the lung, then that's again abnormal, and you would say there's bronchiectasis/bronchiolectasis. There are other accompanying signs such as wall thickening. So normal bronchioles or bronchi have very thin, just about perceptible walls. So the moment you see thickening, it's thickened. Again, we don't measure. Mucoid impaction is when the black is replaced by the white. So you have two white structures going along with each other. And then when we have tree and bud distally, that tells us there's accompanying inflammatory or infectious bronchiolitis. And you can put all of this together. You have these primary signs of the airway artery ratio, the visibility of peripheral airways and lack of tapering, and then all of these secondary signs at the bottom. Now, CT can also help with identifying the etiology, and this is a list of the common conditions that cause bronchiectasis. One of them, we just saw a radiograph in the earlier lecture where the patient had bronchiectasis with dextrocardia, and you can see this typical right middle lobe, lingula, and lower lobe disease. So this is mid and lower zone disease, and this occurs with primary ciliary dyskinesia, of which Carter Jenner's is a subgroup. When we see proximal central bronchiectasis, this is typical of allergic bronchopulmonary aspergillosis or ABPA. And if we see these hyperdense areas of mucoid impaction, we call them HAMs, and you can see them on the lung window images as VY-shaped or gloved finger lesions, then that is also suggestive of ABPA. This is an uncommon condition, but this is a patient with bronchiectasis with tracheal and bronchial diverticulae, and this is Meunier-Kuhn's disease. So you can, to some extent, try and arrive at a diagnosis, though in most patients in the Indian subcontinent, that's India, Sri Lanka, Pakistan, Bangladesh, Nepal, etc., the commonest cause of bronchiectasis is either viral infections in childhood or tuberculosis, right? We move on to emphysema and small airways disease, where CT is gradually playing a larger and larger role in understanding the disease phenotypes. And while we have three major anatomic subtypes, we don't see panlobular, at least where I practice, and so we will stick to centrilobular and paraseptal. And in 2015, Dr. Lynch's group came out with a classification system, again to just bring some structure to all the research that was going on, but we do use these terminologies in practice, and I'll just show the examples to you. So when we see a centrilobular lucency adjacent to a vessel, that's centrilobular emphysema, and if less than 5% of that segment in that section is involved, then we say it's mild. If you can see so many centrilobular lucencies here, then it's greater than 5%, we would say moderate. When these lucencies start becoming confluent, as we see here, then it's confluent emphysema. And when these confluent lucencies involve a large part of the lung with apparently increased air, so you see what looks like a bit of overinflation, then it's advanced destructive emphysema. The same goes for paraseptal. You see this one row of cysts at the periphery, typically in the upper lobes. If the thickness is less than 1 centimeter, we say mild. If it's greater than 1 centimeter, you say substantial or significant. Very often it's not necessary to qualify the extent as long as we can say that there's centrilobular and paraseptal emphysema. Often that's just good enough. So this is just a summary slide that shows the 4 grades of centrilobular emphysema and the 2 grades of paraseptal emphysema. In the future, and I think over the next couple of decades, we will see more and more quantification happening in these patients who have COPD of different types, because this may also help us identify subgroups who may benefit from specific forms of treatment. So we use a software called Caliper right now. It's just investigational, but it's helping us kind of understand what happens in these patients. Another subgroup is small airways disease, where we get constrictive and proliferative disease. Constrictive bronchiolitis is when we have some damage to the bronchioles that has happened in the past, and then that leads to airflow limitation. This is the list of the common conditions that can produce constrictive bronchiolitis. And the way to diagnose this is to have an inspiratory-expiratory pair. So on the inspiratory image, we'll see areas of increased lucency with fewer vessels at the periphery, with air trapping on the expiratory image. So if you look at the left lung, it's normal. On the right, it looks the same, which means there is significant air trapping. This gives rise to a mosaic appearance, and you may or may not have bronchiectasis. Here we do with tree and bud distally. So the Swire-James-McLeod syndrome, and you can see this inspiratory-expiratory pair showing marked air trapping, is an extreme form of constrictive bronchiolitis, and you can see all the findings here. So to summarize constrictive bronchiolitis, these are the signs that we have, and this would allow us to make a diagnosis of small airways disease / constrictive bronchiolitis in these patients. Proliferative bronchiolitis is perhaps a precursor of some forms of constrictive bronchiolitis, where we have inflammation or infection actively occurring in these patients. And another way of understanding this is wet disease, when there's inflammation, which is proliferative, and dry disease, which is constrictive, where that's the consequence of a prior insult. And typically we understand TB. We see this tree and bud, unfortunate term coined in South Korea when the first paper came out, doesn't make sense, but nevertheless, we use the term tree and bud because you get these budding areas here, and this tells us that this is inflammatory or infectious bronchiolitis. But this is usually focal and a little dense. So when you have less dense branching distal opacities bilaterally, symmetric or almost asymmetric, then you're dealing with one of these 4 conditions mostly. So you have diffuse panbronchiolitis, which is an inflammatory condition typically seen in Japan and South Korea, follicular bronchiolitis that occurs usually as part of connective tissue diseases, respiratory bronchiolitis, a term used in smokers, and non-tuberculous mycobacterial disease. This is a non-specific sign, and we know that the lung reacts to insult in a finite number of ways, like about 20, 30 patterns is what we have. This is one such pattern, and everything further needs to be done at a clinical and laboratory level to figure out what the cause of this pattern is. And so that's the summary of proliferative bronchiolitis. We then come to interstitial lung diseases. You have three signs of a fibrosing ILD. You have reticular opacities, the lacy network of subtle lesions that you see starting at the periphery. Traction bronchiectasis, when you have dilatation of the bronchioles along with the reticular opacities, and honeycombing, where you have cysts with shared walls starting in the subpleural interstitium, typically more than one layer extending up to the hilum. We have 5 signs of non-fibrosing ILDs. Mind you, these can occur as part of the fibrosing ILDs as well. So we have ground glass, increased opacity, not obscuring vessels, consolidation, usually occurring with ground glass where the vessels are obscured and you see air bronchograms. Septal thickening, where there's thickening of the interlobular septae, and this can occur with ground glass and consolidation. Ill-defined bronchocentric or centrilobular nodules and discrete nodules like you see here, which can be perivascular, subpleural, or fissural. We'll focus on fibrotic ILDs. When we see these 3 signs, we put them together. If you find reticular opacities with honeycombing, subpleural basal predominance, and nothing else, then that's the typical UIP pattern. If you see all of that, except that the honeycombing is missing, and I think a better term for this is the original term UIP without honeycombing, but it's now called the probable UIP pattern, and that's also suggestive of idiopathic pulmonary fibrosis if there is no etiology. So if you have a 27-year-old with esophageal dilatation and a typical UIP pattern, this is not IPF. This is scleroderma ILD with a UIP pattern. Or this patient who has a probable UIP pattern, has pleural calcified plaques, works in a brake lining factory. This is not IPF. This is asbestos ILD with a UIP pattern. Then you have the UIP-like, but the non-IPF patterns. And so this is also called the alternate diagnosis in one of the guidelines. But here you see honeycombing and traction bronchiectasis. We know this is a fibrosing ILD, but this is not IPF. Why? Because we have ground glass, we have an axial distribution, we have upper lobe disease, we see ill-defined centrilobular nodules. We see a lot of things apart from the history, which in any case doesn't fit in with IPF, and this is quite typical of fibrotic hypersensitivity pneumonitis. Similarly here, we have a fibrosing ILD. We have reticular opacities, honeycombing, traction bronchiectasis, but it's upper and mid-zone predominance. In fact, the basal region seems spared, and this is chronic pulmonary sarcoid. Another area that hasn't been touched upon by any of the guidelines, and clearly we need much more written about this, is variant fibrosis. And Dr. Athol Wells showed one of these patients in his scleroderma case where you had these low attenuation areas that were emphysematous. But we see a fibrosing ILD. We see then different patterns, and I've just summarized them in the slide, but let's say a straight edge on the coronal images, exuberant honeycombing in RA, exuberant honeycombing seen in the anterior upper lobe, which is a sure shot sign of a connective tissue disease ILD. And all of these then are, raise our antennae for CTD ILD. That brings us to NSIP, or the non-specific interstitial pneumonia pattern, a very unfortunate term because we associated non-specific with non-specific. But it's not. It's a specific disease entity called NSIP. But this is a patient with scleroderma. You have temporal and spatial homogeneity. You have reticular opacities and traction bronchiectasis and subpleural sparing. And this is the NSIP pattern. So when we look at non-fibrotic ILDs, we have these 5 signs. And then these occur in different combinations to give us diagnoses or conditions like HP sarcoid, organizing pneumonia patterns, edema, lymphangitis, pulmonary alveolar proteinosis, etc. Lastly, we have cystic lung disease. If you look at articles and textbooks, people will list a whole lot of conditions. In real life, we are looking at about 4, maybe 5 conditions. The cysts by themselves don't usually give us a clue to the diagnosis. But then if you have history and some clinical background, it helps. So a male smoker with thin-walled cysts would typically be pulmonary Langerhans cell histiocytosis. If you see elliptical cysts in the lower lobes, paramediastinal, usually incidental. And the commonest place we pick these up, and we're doing PET CT scans in patients with malignancies, and we see incidentally cysts like this. This is the Birt-Hogg-Dubé syndrome. Lymphangioliomyomatosis, typically in women, reproductive age group, they present with a pneumothorax, and you measure the VEGF-D levels, and you get an answer. And the perivascular cysts we see in patients with Sjogren's, in some HIV-positive patients, other connective tissue diseases, etc. And 2 other conditions that are not uncommon in terms of the uncommon cystic lung diseases would be the cystic metastases, typically from angiosarcomas, and the cysts we see with amyloidosis. But none of this is possible in terms of interpretation if we do not have high-quality scans. And both ATS, ERS, and Fleischner Society have laid down some guidelines. And all diffuse lung diseases, irrespective, need to have an inspiratory-expiratory pair. So you need one high-quality volume inspiratory scan, 1 millimeter reconstructed at 0.5 millimeter intervals or thinner. You also need an expiratory scan. Now, if you have interstitial lung disease, at the first instance, a prone study needs to be done. And given the fact that we still have films being documented in most parts of South Asia, then we should also be able to give soft copy images or links, etc. And if you're filming, then 12-on-1 to be able to see things well. So that was today's idea, to introduce you to the fascinating world of CT in diffuse lung diseases. And it's a little more than just interstitial lung diseases. We're just, barely touching the surface. And I've been doing this now for 25, 30 years. And you still think you don't know much anyway. For those of you who might be interested, especially residents, I did an entire series on Zoom somewhere between August and October. All of these lectures are available. They're all free. You can just go through them at your pace. They're typically about an hour. And there's a 15-20 minute Q&A at the end with the people who are attending. And I've been told that they're quite interesting to go through. If you'd like to subscribe to my WhatsApp channel where I put up some cases on and off, then that's the QR code. Thank you so much for listening to me, and I hope you have a great conference. Yeah.
Thank you very much, Dr. Bhavin. We'll move on to next lecture.
Our next talk is on new advances in imaging modalities in chest diseases. It's be delivered by Dr. Sumudhu Palihavaddana. She's a consultant radiologist at National Hospital for Respiratory Diseases, and she's a known personality for respiratory medicine in Sri Lanka. Over to you, Sumudhu.
Okay, good morning. First, I may thank the Council and the President of the Sri Lanka College of Pulmonologists for inviting me to this conference this year as well. So during the recent years, or for that matter decades, we have witnessed an explosion in medical imaging techniques. So such advances of interest to chest medicine would include functional imaging of the lungs with CT and MRI, which was an area confined to scintigraphy and SPECT imaging. Furthermore, new advances in lung nodule detection and characterization, and the emergence of MRI in imaging of the lung parenchyma. and the mediastinum have changed our horizons in pulmonary imaging. Therefore, during the next few minutes, I will be reviewing briefly 3 of the relatively new techniques, especially of importance to chest diseases. So these are the areas that I wish to talk about. The reason that I have chosen these 3 areas is because they have quite a relevance. The topics that I'm going to talk about has some relevance to chest imaging, and also some of these techniques, although you may not be aware, is possible here in Sri Lanka. So first one, dual energy CT. So that is the type of CT, as the name implies. We use 2 levels of energy instead of single energy level. Now, single energy is the one that we already have here for imaging, and that is called single level energy CT. Now, what I'm going to talk about is dual energy. So what is the advantage? Now, we use 2 levels of energies for imaging, which make it possible to integration of materials that have different attenuation properties at different energies. And that would make it possible for us to reconstruct the image type, reconstruct multiple image types instead of single type. I'll show you what these are. And also the other advantage is, now we know CT is for structural imaging, but dual energy CT is possible of doing functional imaging as well. Now, these 2 slides I have just included for the completeness of sake, because the physics associated with dual energy CT is very complicated, so I'm not going to go into details. Now, these are the types of dual energy CT scanners available. Right, so we'll come to the clinical, the applications in clinical practice. Now, everything depends on the post-processing of the images. So we have a dual energy CT scanner, and then we use multiple post-processing techniques to develop multiple image types. Now, I have listed here the main types of post-processing applications. So we'll go through them one by one. The first one is called virtual monochromatic image reconstructions. We'll consider it with an example. Now, a common clinical scenario that we encounter day in and out would be, we go and do a CT pulmonary angiogram and then end up with very suboptimal contrast attenuation within the pulmonary arteries. So the images are non-diagnostic. So then we say, okay, we'd better repeat the CT the following day. Now, with VMI reconstruction, it is not necessary. What is possible is, the application is capable of enhancing. All right, okay, yeah. Right. So this is the original set of images. So the contrast density within the main pulmonary artery is 120 HU. It's very suboptimal and is non-diagnostic. And the same set of images has been post-processed using VMI, and here the right. Okay, the second set of images. No, that's okay. So the second set of images shows the reconstructed main pulmonary artery with an HU value of 304. Now, we have not given additional contrast, but using the application, we have optimized the already available iodine attenuation within the pulmonary vessel to develop diagnostic images. The second set of images, again the same. You can see that the initial set of images, so the initial set of images shows suboptimal contrast within the pulmonary arteries, and the second set of images, which are reconstructed with VMI, shows good contrast, apparently good contrast, and diagnostic images. Now, this patient was in renal impairment. Now, we all know patients in renal impairment cannot take up the normal contrast dose. Now, this patient, in addition, is having a chronic aortic dissection. So what has been done is the patient has been given only 30 ml of contrast. Usually for an aortic angiogram, we give around 100 ml. So we have given only 30 ml, and this is the initial set of images with suboptimal contrast density within the aorta. And they have been reconstructed. So it has been reconstructed using VMI. Now we have adequate contrast density in the aorta, and we can well see the chronic dissection. So the bottom line is, patients who are in renal failure can have dual energy CT studies with significant reduction in the contrast administered, and the kidneys can be spared. So this is a patient who has an endovascular leak. The initial set of images barely show the leak, but once reconstructed, we can see the leak. So we have not given additional contrast. We have not repeated the CT. It's just the reconstruction model. Right. Coming on to some other applications that are possible with dual energy CT, pulmonary thromboembolic imaging. Now, when we do the conventional CT, we know that we can look for the filling defect, but we can't comment about the perfusion defect, the perfusion status of the lung. But with dual energy CT, we at the same time looking for the filling defects, we can also image for any perfusion defects in the lung. So, and also by doing so, we can quantify the filling defects. Now, this is an example. You would see that there are filling defects in the proximal pulmonary artery with corresponding bed-shaped areas of perfusion defects. So at the same time imaging for filling defects, we have already identified the perfusion defect. If not, the patient has to undergo VQ studies or SPECT studies to look for perfusion defects. Now, assessment of pulmonary nodules. Now, when we encounter pulmonary nodules or masses, you know that what we do is we do a pre and post-contrast set of images, and we measure the post-contrast attenuation or enhancement, and if it is more than 20 HU, we assume that the lesion that we are looking after is malignant. Now, with iodine mapping in dual energy CT, we can do a single set of images, and post-contrast after 90 seconds from administration of IV contrast, and then assess the iodine concentration. Now, iodine concentration is different from contrast attenuation or enhancement. Now, it has been found that the iodine concentration in a nodule is an indicator of the neovascularization and hence the metabolic activity of the tumor. So without doing two phases, pre and post, we do a post-contrast and then assess for the iodine concentration within the nodule. So therefore, one thing is the patient is spared of radiation, and also it has been found that the level of iodine within the lesion is a better indicator of its malignancy or otherwise than the contrast enhancement. So it has been found and described that dual energy CT with iodine concentration is a possible substitute to FDG PET CT in the evaluation of lung tumor response to treatment. There are a few other applications that are possible with dual energy CT. So one of the, I will take up one of the clinical scenarios. So you have a patient in the ward who became all of a sudden agitated, and then you would think of an intracranial bleed, and then the patient would end up having a non-contrast CT brain. And now our concern is he having an intracranial bleed? And then we encounter this focus of high density in the brainstem, and then one would wonder, is it bleeding or is it calcium? So how do we know? Then we apply this application, virtual non-calcium imaging, and then the images which are developed, you can see that you don't see the skull vault even. So even the focus which was there in the brainstem is absent. So that means this focus of high density was calcification, not bleeding. Similarly, this patient also had a similar lesion in the brainstem. VNC was applied, but still we can see the focus of high density. So that means this is not calcification, this is bleed. Virtual non-contrast imaging, now we usually do a pre and post contrast set of images, but here it's not necessary to do pre-contrast, we straight away do the post-contrast set of images, and the application is able to subtract the iodine attenuation within the lesion. So you do the post-contrast set of images and then subtract iodine from that, and that will produce the non-contrast images. So that is called virtual non-contrast imaging. Right. So that is all for dual energy. So I thought those applications would be of interest to you all in the day-to-day practice. So we will go to another newer technique in lung imaging. Functional lung MRI is an emergent technique that is able to overcome a lot of the drawbacks that were associated with MRI lung imaging. You know, the imaging of the lung with MRI is literally impossible because there's not much of protons in the lung, because lung is an aerated organ, not an solid organ. So there's not much of H2O or water. And in addition, there are multiple interfaces between air and soft tissue, and also there are a lot of artifacts generated by the cardiac pulsation, vascular pulsation, and respiratory movement artifacts. So all these drawbacks have been overcome by newer techniques, and now functional lung MRI has become a possibility. Now, all this time, lung functional imaging was done by ventilation perfusion studies and SPECT. And you all know the outcome of that. The images are of very low resolution, and the acquisition time is very long. And also, those involve radiation to the patient. But with lung functional imaging, all three of those drawbacks have been addressed to a significant level. Anyway, the radiation part is completely eliminated. So for functional lung imaging, we use hyperpolarized gas MRI. So that is the established functional lung imaging technique that is available at the moment, and it uses noble gases. So noble gases are the gases that is available, those are inert gases that is available in the group 18 of the periodic table, and would include helium, xenon, neon, argon, gases like that. So what we use for medical imaging is helium and xenon. So we use them in a very smaller quantities. It's not toxic to the human body. So there are types of imaging that we use. Do static ventilation, dynamic ventilation, diffusion weighted, and there are a few other techniques as well. So in static ventilation, what we do is we ask the patient to take a good deep breath in and hold for a few seconds, and then measure the distribution of these gases inside the lung. So if there are ventilation defects, that can be seen as signal void, and also those defects can be quantified and expressed as a percentage of the ventilated lung. So this is an example here. So we have normal adults with well-aerated lungs with helium gas. There are some filling defects along the bases, but that is normal in adults. And this is a patient with COPD. Now this, the color code is personal, that can be altered. So there are filling defects, multiple filling defects in a patient with COPD. So that is static ventilation. So these filling defects can be quantified. Dynamic ventilation imaging, here the imaging is done during an entire respiratory cycle from inspiration to expiration. So that would be good for analyzing of air trapping in emphysema, and also to assess the proximal airways. Now this is a mapping of a dynamic ventilation. So the top row of images are of a normal adult, and the bottom row is a patient who is having COPD. So you can see as the respiration goes on towards the expiration, there's more and more air trapping inside the alveoli. The last will be diffusion weighted imaging. So that again is used to see the extent of emphysema and alveolar dilatation. Right, so these are the clinical indications for lung functional imaging. So lastly, I would take up MRI imaging in thoracic disorders. Now, there are a few sequences that were developed very recently, and those are called ultra-short TE and zero TE, which are meant for imaging of the lung parenchyma. We know that usually it's not a very favored method. MRI is not a favored technique for imaging of the lung parenchyma. We all usually like to go for CT. So in 2020, Fleischner Society published a report which provides the consensus report opinion regarding the appropriate clinical indications of pulmonary MRI imaging in oncology and pulmonary diseases. So these are the indications. So the first category, the currently available applications for imaging of the lung parenchyma would be dealing with lung cancer staging, pulmonary nodule characterization, pulmonary nodule detection, pulmonary hypertension, and pulmonary thromboembolism. Now, this is an example of pulmonary nodule detection using short TE, ultra-short time to echo sequence. So the first set of images deals with a low density, low radiation CT of this right upper lobar nodule, and the corresponding imaging with MRI. You can see, there is no depletion of the resolution. It's more or less the same. And here we have a ground glass nodule, low dose CT, and MRI. So the MRI is coming with no radiation. So this technique, if we can acquire this, can be used for pulmonary nodular detection and characterization. DW imaging or diffusion weighting imaging and dynamic contrast enhanced MRI can be used for pulmonary nodule characterization. It has been found that NIVA sequences with dynamic contrast imaging needs less than 30 seconds per breath hold for characterization of the nodule, whereas the same amount of data to be obtained with PET FDG would take around 2 hours. Lung cancer staging. Now, MRI is having its say in lung cancer imaging as well. Initially, it was thought that it is better for T imaging, but now it has been found that it is better in N staging or nodule staging, and also for M staging with diffusion weighting. I will show you an example where lung cancer staging with MRI has done better than PET FDG. So this patient is having a nodule in the right upper lobe with associated right hilar lymph node and a subcarinal lymph node as shown in these turbo images. And in DW images or diffusion weighted images also we can see all these 3 lesions. But this patient had a PET FDG study as well, which showed the right upper lobar nodule and the right hilar lymph node, but not the subcarinal lymph node. So this was erroneously staged as N1, whereas it was really an N2 tumor. Mediastinal tumor characterization. Now we know that mediastinal tumor imaging is done with CT, but now with this development of newer sequences, MRI is having a bigger say in mediastinal imaging with regard to the tumor location, infiltration, and invasion of the adjacent tumors, adjacent structures. However, since 2003, chemical shift artifact imaging has been in use for differentiation of thymic hyperplasia from other thymic tumors. So another example of mediastinal tumor characterization, I would just skip that. Then pulmonary thromboembolic disease, also like with the development of newer sequences, the time required to acquire a CT pulmonary angiogram has become more and more less. So the total time of acquisition is dependent on the depth of the evaluation, and it will take from 3 to 20 minutes. So if you want the basic set of images, you can get it done in 3 minutes, but if you want to do the pulmonary function and assess the heart and the myocardium, then it will go on for about 20 minutes. So some pictures comparing CT and MRI. So there is no compromise on the resolution, you can see. And again, a similar set of images. And lastly, pulmonary hypertension and right heart strain also can be imaged to a better degree using MRI. So in summary, dual energy CT is capable of functional lung imaging in pulmonary thromboembolic disease. Virtual monochromatic imaging is capable of reducing the contrast dose to the patient. Virtual non-contrast imaging can cut down on the radiation dose to the patient. Lung functional imaging with MRI provides images of better resolution in a fraction of time taken by scintigraphy. MRI would be a better modality for CT for lung nodule detection and characterization in lung cancer screening and follow-up in the future. Lung cancer staging with MRI may appear promising with DW and STIR turbo imaging. And recent technical developments in MRI angiography, pulmonary angiography, has significantly shortened the acquisition time in pulmonary thromboembolic disease and can be considered in routine clinical practice for young adults and pregnant women. Thank you for your attention.
For the excellent talk on new advances in chest imaging. We'll move on to the next topic.
The next topic is on radiological interventions in respiratory care. Dr. Chintaka Appuhami will deliver the lecture. He is a senior lecturer and consultant radiologist attached to University of Kelaniya. Over to you, Chintaka.
Thank you for the invitation. Without much delay, I will go into the lecture. The radiological interventions play a crucial role in respiratory care across various clinical scenarios. The imaging modalities we use are the fluoroscopy, ultrasound, and CT for real-time image guidance. I will briefly discuss about thoracentesis and pleural biopsies, chest tube insertion, embolization, lung biopsy procedures, and tumor ablations. Pleural interventions. The commonest presentation in everyday practice is the pleural effusions, and it can be both simple pleural effusion and organized or loculated pleural effusions. So in ultrasonography, you will see the costophrenic angle and the diaphragm. The pleural effusion will be anechoic or hypoechoic or with turbid material, and underlying consolidated partially collapsed lung can be seen like this. Whereas in the organized effusions, there can be pleural septations, so the management will be differ. So ultrasound-guided pleural puncture, we usually advocate supine position or a recumbent lateral position. The costophrenic angle is selected in the ultrasound scan, and the needle is advanced into the pleural space. So using the same technique of Seldinger, over a wire, the track is manipulated, dilated in order to accommodate 7 or 8 French self-retaining or locking pigtail. So this will be connected to an underwater seal. Pleural-based masses. So both ultrasound and CT are useful. So this ultrasound scan clearly demonstrate a mass with ill-defined outline surrounded by aerated lung. So this is the pleura, the mass projecting into the peripheral lung. So real-time ultrasound guidance is used to advance a coaxial needle. Through that, we can take several samples, and on our way back, we block the track with gel foam in order to prevent leak of air as well as to prevent hemorrhage. Lung biopsy. Lung biopsy procedures have evolved significantly over the years and transiting from traditional surgical approaches to less invasive methods that offer reduced risk, shorter recovery times, and enhanced diagnostic yield. The CT is the preferred imaging modality. This is one such example. Patient is in prone position. The left lung apical segment mass. This is the coaxial needle, and biopsy was taken. And I would like to draw your attention for the fissure, the masses related to fissures. It will increase the complication rate. So we try as much as possible to keep away our needles from the fissures. Not only that, but the bulla cavity and emphysematous lungs also will increase the rate of pneumothorax. The mediastinal mass biopsy is a bit tricky, but it can be done like this. So again, CT will be the preferred technique, and we usually advocate contrast imaging prior to advancing the needle, because we want to differentiate the major vessels and cardiac structures from the mass. So when we insert the needle, care needs to be drawn to this internal mammary arteries as well, right up here. So biopsy can be taken, and again, the tract will be blocked with gel foam. Cystic lung lesions also can be biopsied, but the needle should be targeted to the periphery or the solid area, because advancing a needle into a cavity again increases the risk of pneumothorax. This is one such example of a massive pneumothorax following lung biopsy, and in some series they reported as up to 40% of pneumothorax prevalence. And this patient with a small nodule and targeted biopsy was taken. Following that, the patient developed a massive pneumothorax with tension, and it was subsequently relieved with a pigtail insertion in the same setting. This is how you see the inserted pigtail on a chest radiograph. Pulmonary hemorrhage is another complication. Following this biopsy from this nodule, there was a massive intraparenchymal hemorrhage, and there is consolidation and a small pneumothorax at the periphery. So this was also conservatively managed. But in this patient, the pneumothorax is rare, but it is a non-complication. So we may need to insert an IC tube or a large bore pigtail drainage to relieve the symptoms. Now I will move on to the vascular interventions. The bronchial artery embolization is the commonest intervention we carry out for respiratory care. So it is a minimally invasive procedure used to treat massive or recurrent hemoptysis. I'm not going into details about the etiologies. Bronchiectasis is one of the commonest causes. I like to draw your attention to these. There are a lot of vascular variations when it comes to bronchial arteries. The commonest type also only present in 41%. That is the intercostal trunk from the right side. It will divide into right bronchial artery and the intercostal artery, and two left bronchial arteries. So there are so many variations. So we need a preoperative image evaluation and a good diagnostic aortogram with a pigtail before deciding for the intervention. This snapshot demonstrates the commonest finding of right intercostal bronchial trunk. It goes and divides into right bronchial and the posterior intercostal artery. This is an example snapshot image angiogram of a DSA demonstrating the common trunk, and this is the right bronchial artery and dilated posterior intercostal artery as well. This angiogram shows the anatomy which I described now. There is pathological blood supply from the bronchial artery, and it was subsequently embolized, and the complete knockoff of the bronchial artery was achieved. And another variation, the right bronchial artery directly arising from the aorta. So that's why I told you the pre-intervention imaging may be very useful. Now this patient, we know the area, the location of the origin of the right bronchial artery. So superselective cannulation was easy, and this is the pathological blood supply towards the central part of the lung, and it was embolized. Early venous shunts. Sometimes you may have come across that the patients are revert back without doing the intervention, or rather not embolizing, saying that there is venous shunting or arteriovenous fistula. So in severe cases, there is early venous filling, and sometimes there can be fistulation between the arteries and the veins. So we don't embolize because the embolic material can go into the left heart and shoot, and patient may present with strokes and ischemia of peripheries. So I was talking about bronchial arteries, but there are several non-bronchial systemic culprit arteries for hemoptysis. There are several, namely all the posterior intercostal arteries, the inferior phrenic artery, and then comes the internal mammary, thyrocervical, costocervical, direct subclavian, lateral thoracic, all can contribute depending on the site of the pathology. This is angiographic phase of cross-sectional axial CT image, clearly demonstrates multiple feeders from the anterior intercostal arteries supplying to this abnormal pulmonary area. This is another example, snapshot image of left subclavian angiogram, nicely demonstrating large direct branches from the subclavian artery, as well as dilated and tortuous internal mammary supplying this left upper lobe area. The intercostal arteries are also contributes significantly when it comes to the to hemoptysis, and in this example, this is a normal posterior intercostal artery, whereas this is pathologically dilated and it gives multiple feeders into the parenchyma. So this needs to be embolized. Very important image. There are multiple spinal arteries, spinal contributors. So they are like hairpin, gives the appearance of this hairpin. One major artery is artery of Adamskiewicz, which contributes to the anterior spinal artery in the mid-thoracic region. So when we see this, we don't embolize. We should advance our catheters distal to the origin of the spinal contributors. So otherwise patient will present with spinal ischemia. This is an example of a thoracic wall AVM. This MRI shows significantly enhancing well-defined mass-like area in the right chest wall. So biopsy was proved to be a AVM. So we decided to go with pre-surgical embolization, and it was supplied by the right internal mammary artery, which is dilated, as you can see here, and there are multiple feeders supplying the AVM. And this was subsequently embolized and surgically removed thereafter. Pulmonary AVM, congenital and acquired, pre-embolization imaging is vital to make sure the number of lesions, the size of the lesions, and location of lesions. So this is one such example of bilateral AVMs, and this was super selectively cannulated, and embolization was carried out with multiple coils. Catamenial hemoptysis, I'm just showing this because this patient presented to us a couple of years back with cyclic pulmonary hemorrhage that is synchronized with female menstruation, which is associated with the presence of intrapulmonary or endobronchial ectopic endometrial tissue. And the CT showed a patchy area in the right lower lobe, and subsequently she underwent bronchial artery angiogram. This is a selective angiogram of the common trunk, and this is the right bronchial artery leading into a abnormal vascular blush here, and this was embolized, and a patient improved symptomatically. Tumor ablation. Image-guided percutaneous lung ablation is a technique equivalent to surgery and stereotactic radiation therapy to treat patients with early-stage non-small cell lung cancer or oligometastatic lung disease. So modalities available includes radiofrequency, microwave, and cryoablation. And patient selection is we should do it carefully in order to prevent complications and to get a better outcome. In follow-up imaging, both CT and PET-CT has a big role to play. So these are the indications, and there are absolute indications as well as alternate indications. This is one such example of a ill-defined metastatic deposit in the left lung. The patient was in the prone position, and the antenna was advanced into the abnormal area, and the ablation was carried out. This is how you see immediately after post-ablation as consolidation and with bit of hemorrhage. So this needs to be followed up to see the complete outcome. So in summary, radiological interventions are indispensable in respiratory care, providing valuable diagnostic, therapeutic, and monitoring capabilities across a wide range of respiratory conditions. They enable healthcare professionals to make timely and informed decisions, improve patient outcomes, and enhance the overall quality of respiratory care. Thank you.
Thank you, Chintaka. You have saved some time also for us. We have about 10 minutes for any questions from the speakers. If you have any queries, you can clarify them now.
My question is to the second speaker. In the remarkable tour de force of covering all of ILD on CT in 10 minutes flat, I don't think I've heard that before. So I have a challenge to the second speaker. Can you answer in 6 or 7 well-chosen sentences how you would use CT in monitoring interstitial lung disease?
So the way we do this is that if we have a patient with IPF diagnosed as part of a multidisciplinary meeting, then the typical follow-up for a patient who doesn't have acute exacerbation in between would be either yearly or biennial, depending upon the progression with FVC or when the respiratory physician looks at the patient and decides the time of follow-up. If the patient, however, does have any acute exacerbations in between and manages to survive those, then we may image a little earlier. Now, if it's a patient with hypersensitivity pneumonitis and it's the first presentation with non-fibrotic HP, then we may even image at 3 months or 6 months to see if the patient's anatomic improvement is paralleling the clinical improvement or not. This also allows us to set a baseline, because a good number of these patients, even if they've improved clinically, may have residual disease that can create a slow burn of fibrosis over years. And so even if we don't image them at yearly or biennial intervals, you have one baseline that gives you a sense of how they might progress over a period of time. So it's variable. I mean, there are no guidelines, and it depends upon how the patient is doing and what the respiratory physician believes is important when it comes to anatomic stability or progression.
So just to draw you out a bit, I think you're saying that you don't repeat CT with an unthinking regular protocol. You're probably repeating it if you have a particular question to ask using CT in an individual. And I'm asking you this because a lot of people use CT like lung function tests, even when the lung function's making it clear there's progression in IPF, but you're not advocating that. Is that correct?
That is correct, but with some caveats. So if a patient has documented IPF, I would argue that even if the FVC remains stable, there could still be anatomic progression. And I think on an average, at least after 2 years, if not earlier, but at least at 2 years, if the patient hasn't had any other scans done, it may be a good idea to repeat a scan just to make sure that there's no anatomic progression. But then the type of disease matters. So if it's documented IPF, 70-year-old smoker, even if the FVC is doing well, you might want to check that. Plus, if it's a CPFE, then the FVC doesn't work, and so then again you want a better parameter, etc. So
I don't want to hog all the time, but just one more quick comment. Some people believe in IPF you should perform CT annually because of a high prevalence of picking up cancer. And I don't know what you think about that.
yeah, so
There's arguments
if the
around the world.
patient's a smoker,
Yeah.
so if the patient's a smoker, you've put them on an LDCT program, then you're scanning them every year for lung nodules, and you'd also look at the interstitial lung disease. But if he's a non-smoker, and if we accept that at presentation 10% of IPFs, even non-smokers are supposed to have lung cancer, and that maybe they also have an increased incidence of lung cancer on a yearly basis, then do you bring them in every year, or do you at least wait 2 years? I don't think we have answers. So I'd bow down to and I'd defer to the clinical physician to decide what's a good time to scan. But I would say at least not later than 2 years. I think it's a good ballpark that once in 2 years, a potentially progressive ILD should be scanned.
Thank you.
Any more questions?
I congratulate all 4 speakers for giving excellent information and knowledge. My question is to Dr. Chinsaka. With regard to embolization of the bleeders, hemoptysis, I know most acute case or major hemoptysis we may refer and we may negotiate as a personal case, but moderate hemoptysis, in our setup, we take dates. So, when the patient is in waiting list, will it, affect your success of the procedure? Because the patient may not be bleeding by the time the patient get the opportunity to go for the embolization.
When there is no bleeding, usually the blood vessels are smaller. And when there is active bleeding, the blood vessels, not only the blood vessels, but also the abnormal vasculature, the tumor blush, the vascular blush is very prominent. And so it is certainly in like you said, in moderate cases, sometimes we may not be able to embolize when there is no hemoptysis at the time of the intervention. So that will affect the management, yeah, for sure.
And one more question again for you. When you do the pleural aspiration, I know I have encountered several patients, in fact, having disastrous complication with regard to re-expansion pulmonary edema. Have you got sort of a guideline as to how much you aspirate at once, or you prefer to put a catheter and do graded aspiration or graded drainage, so 1 liter or 800 ml, so how can you prevent that?
We usually monitor continuously the SpO2, the pulse rate, and the respiration. So we usually don't follow a guideline as such, but certainly when we are aspirating, patient is under monitoring. So if there's any drop in the SpO2, or if there's any symptoms like the patient will start coughing, so that's my endpoint for the aspiration for that particular moment.
For that now, because the BTS statement published about last year, now there's clear evidence that how much you should aspirate at once. So it's about 1.5 liters at once, and then we are doing hourly 1 liter and until the drain stops. So if the patient becomes dyspneic or having any cough or any distress, we can discredit, but that is the evidence at the moment which is published in the BTS guideline. So it's 1.5 liters at once and then 1 liter hourly.
But maybe 1.5 for the European community. Honestly speaking, one of my patients in private sector died last week, aspirated 1.2 liters, and patient went to ETU and then taken into ICU, put tubes, resuscitated, and patient died the next day. Maybe our people are smaller, but same is true for, I'm a surgeon, same is true for thoracoscopy or VATS also. Our dimensions, we have to, figure out our dimensions are small because our people are mostly small people. So maybe the number should be a bit lesser for our community.
It should be symptom-based, especially if the patient starts coughing, and as you said, that we see a little bit of distress at the patient and the saturation is dropping. I think that is the time that we should stop, even after 500 milliliters. And then slowly, because we are not in a hurry, so especially if we are putting a pleural catheter, we can slowly drain it out later, because we are not in a hurry. So yes, 1.5, yes, in a normal population would be okay, but I think always we should be guided by the clinical presentation of the patient.
I think we have come to the end of this symposium. Let me thank on behalf of the Sri Lanka College of Pulmonologists to all 4 speakers for the excellent contribution they have made this morning. Thank you.
Thank you, speakers, for that insightful and quite interactive series of presentations. Now I cordially invite the chairpersons to present the tokens of appreciation to the speakers. Firstly, Dr. Saman Kularatna. Next, Dr. Bhavin Jankeria. And next, Dr. Sumudu Palihevadana. And finally, Dr. Chintaka Apuhami. Next up, let me invite Dr. Bodhika Samarasekara, the President of the Sri Lanka College of Pulmonologists, to present the tokens of appreciation to the chairpersons. Firstly, to Consultant Respiratory Physician Dr. Ishant Pereira. And next to Consultant Radiologist Dr. Shanta Hetiarachi. Thank you, sir. Ladies and gentlemen, we cordially invite you to enjoy the tea, which is now served outside. And please be kind enough to return in 15 minutes for us to start Symposium 3. Thank you.